Okay.
All right, you can hear me okay? And see the screen?
Yes, ma'am.
All right, I appreciate it. As Matt said, my name's Kim Stanley. I'm the Chief Client Advocacy Officer for EMSMC, and I'm honored and privileged to be able to present to you all today. I have just a few slides, certainly open for discussion, interaction within the documents that we're going to share, but excited to present to you all today. One of the things that I'm using a lot of the information from is this EMS Financial Index that Matt and I worked on together, but it's a PWWAG resource that was actually just published today, and it is now available on their resource hub. And really, kind of to put this into a framework, EMSMC processes about 6 million transports a year. And we wanted to see ourselves differently. We wanted to say, okay, there's no one agency in which we can glean that much data from. And so how can we use that data and be able to benefit the entire industry? And so actually, this is the second publication. There was a Q1 index report that came out early April. This one being released today, early August, and then we want to continue that. So we would welcome your feedback as to some of the indices that you might want to see, just the data that we're able to share from an industry perspective. The very first thing I want to talk about, and as I said yesterday in our webinar, it's a soapbox for Matt for quite a while, and it's now a soapbox for me. And I really wanted to dive into what does this treatment in place look like, or treatment no transport as we used to call it. And let's look at the data surrounding the payment for those services. And so we're trying to encourage more and more agencies. I think at the very last bullet point here is really telling, is the GACDS report said that only about 9.5% of EMS providers actually bill for a TIP or a TNT service. And most of that has just been either tradition, they know that Medicare doesn't cover it, they don't want to burden the patient with the bills and so forth. And really, in a lot of conversations that we're having with our customer base, they're saying, is the view worth the climb? Because that's usually where our complaints come from, in terms of the patients receiving bills, especially that Medicare population. And so Matt and I wanted to look at this a little bit more intently and say, okay, who is actually paying for these services? And then the bigger picture here, and really what I wanted to hit home, is that it's really difficult from an advocacy perspective. So everybody's talking about going to CMS and saying these treatment in place services are a valuable asset that EMS provides across the country. It's saving Medicare money, it's saving the commercial insurance companies money. But if only 9.5% of our providers are billing that across the board, it's really hard to continue to advocate and help Medicare to understand that. So really, like I said, it's become a talking point for me everywhere I go. I try to talk about it and really understand a little bit better and help our clients to understand that as well. Obviously, Anthem Blue Cross Blue Shield back in 2018 came out with a press release, and it was the voice heard around the world within our industry that Anthem saw the value of a TNT and that they were going to start paying for that. And more importantly, their reimbursement was very close to that of what the transport would have paid for those services. United Healthcare has actually come to the table now. We've been successful with companies like Cigna and Aetna. Most of the time, that's actually putting it into a network contract. But there's lots of opportunity on the commercial side for them to recognize the cost savings that's in it for them, and for us to be able to establish some charges around that. We're also seeing certain Medicare Advantage plans, and then depending on the state, certain Medicaid and Medicaid MCO plans that are covering those services as well. Obviously, traditional Medicare doesn't cover that, but that's something that we're working on, and with the industry's help and getting more charges established for it. The other saying that I take from Matt often is, what does it cost for you to put an ambulance in front of an address? And when you really analyze your cost around this treatment in place and understanding the value that it represents, not only to the patient and to the insurance companies, understanding that, reimbursement is tied to what you're charging for those services. And even in the ET3 model, Medicare made a huge statement by saying that not only was the TIP service going to be covered, but there was no financial disadvantage for you deciding not to transport the patient, meaning that the reimbursement was going to be very close to or actually equal to the transport if you had transported the patient. Another interesting thing that I'll go into, and I wanted to share some information here, some of these state balance billing laws, and we're seeing those pop up across the country. I believe that there are, last count, 18 state balance billing laws that include ground ambulance, and I believe that there are 10 or 11 or 12 additional ones that are pending legislation right now. And they're actually adding to that state legislation the requirement for them to pay for services like treatment in place. And I'm illustrating this Illinois bill that is still pending at the moment, but they've actually put it in three categories. One being an evaluation without transport, a treatment without transport, and then the paramedic intercept services. So those balanced billing laws are great opportunities for us to force this legislative effort or this advocacy effort in ensuring that those services are covered by the insurance companies. And then on the slide, you see this is just a snippet from the Anthem policy and how they evaluated and decided to reimburse for the ambulance response and treatment without transport. So what's the data behind it? I'm just showing a couple of examples. Honestly, you can set up these processes in place. So the first question I get from our customers, as I said, a lot of discussion around, we transport 30,000 individuals and we might actually bill for 5,000 treatment no transports, but proportionately they represent more complaints from our community, from our citizens, from our patients than the actual transport, because they are not recognizing that there's a charge for the service. And so is that view worth the climb? And these are just two examples of some policies that we've put together, and that allows the client to decide what's right for their community in which, a treatment no transport is built. Sometimes I have clients to say every time we lay hands on the patient, meaning that we did an evaluation of the patient, we check vitals, then there's a charge. Others say, no, it's only reserved for those where it's ALS procedures or, and really what that does is eliminate some of those like lift assist or even MVA calls where the patient didn't actually call 911, all the bystanders called, they did not really have anything more than just an evaluation and they refused transport. But I wanted to illustrate the ability, because Medicare doesn't really have any guidelines set up around it, you do have the flexibility of creating policies that you're basically that your community could withstand. The other thing that we looked at, and this is part of Matt's analysis in this report that was released today, is what is the percentage of treatment in place claims that are paid by any source. So this was basically saying that the payment on these treatment in place services was not zero. We had collected at least some dollars. And that might be from the insurance company. It might be actually billing the patient separately for those services. But you can see across the board about 38%, 39% call it, that we're receiving payment on. And that sounds kind of counterproductive of what I've just said and why you need to bill for these services. However, if we're going to move that needle, we've got to have more support from the industry in truly understanding that this is a valuable service and it's a service that you all have provided and should be paid for it. So the next question is what's the reimbursement for these services? So we did some analysis based on, as I said, EMSMC data. This is calendar year 2024. And we did this by region to determine what is the average reimbursement. And we're finding it's around $400. Nationally, around $400 is paid for a treatment in place service. But if you look at that, it's very different based on the the different regions. And this being mostly California data, but you can see that they're getting as high as $1,100. Whereas my friends, where I live out in the southeast, is around 157 and even 144. But I do think that there's a huge correlation between the amount charged and the amount being reimbursed. So if I look to California or the western states, $1,151, but they're billing closer to $2,100, whereas my friends down in North Carolina, for example, may only be billing $212 as their average charge, and the reimbursement is actually, correlated to that and why it's so low. And, I understand. I mean, I come from North Carolina, that's where I live, and we have a large population of clients here. And it was, as we started to see the value of the service, they incorrectly looked at it to say, okay, if we're going to charge 600 for transport, let's just throw out a $50 charge or a $100 charge, or even, on average 212. They were devaluing the service that was being provided to those customers, and the reimbursement is based on how they have set that up. So I'm going to switch gears just a bit, and certainly, like I said, if it's a small enough group, if you have questions, feel free. Switch gears a little bit more. So in our first Q1 index that we published, we looked at this ALS to BLS ratio. And so we were trying to really dive into that to determine, how does that all play out? And Matt, wisely so, said, wait a minute, there's some non-emergency in here that's non-emergency transports in the data. For Q2, let's just take a look at truly the emergency response, the 911 calls. And let's see how the ALS and BLS percentages take shape in that. And so this is the data, again, split by the various regions. In the document it'll tell you how we categorized each of the regions. But nationally, we were showing about 60.8% transports are billed at the ALS level. The GADCS reporting actually showed around 56.1%, so a little bit different, but very similar. But the most important, I think, was we dug into our data from EMSMC's perspective a little bit further than that, and decided, okay, what are those clients that actually have an ALS assessment policy in place, and how does that compare versus those that do not? And I think that's where we see the bigger gap. 70% or 70.5% is our ALS percentage for those clients that have implemented an ALS assessment policy, compared to about 51% for those that do not have an ALS assessment policy. And so just putting a lot of education around this, I remember, and have been in the industry long enough to remember back in negotiated rulemaking days. So prior to 2002, when the ambulance fee schedule was generated, there was a lot of discussion around ambulance policy. It was the beginning of Chapter 10 of the CMS manual, and there were so many discussions around that room that I'm going to send out an ALS unit, and I'm going to send that into service based on the reported patient's condition at the time of dispatch. And I highlight that here because the reported condition doesn't mean it's their actual condition. It is based on the information that you were given at the point of dispatch to determine whether or not an ALS assessment is required. And I'll tell you, I sit in front of Medicare auditors all the time, and they do not like this rule. But if we educate them, and we've been very, very successful on appeal and through audits to educate them of what this ALS assessment rule was really around. The example that we used at the CMS level back in the day was, you get the call for an unconscious person. You arrive and find that the guy's just had too much to drink. Everybody knows Johnny. He has passed out. We're going to transport him, but we're not going to do any ALS interventions. But you didn't have that information at the time of dispatch. It was dispatched as unconscious. And really what fits this model, and what I've been able to use is this little chart here. I have this in almost all of our audits that we're getting down coded from ALS to BLS, saying that we didn't actually provide an ALS intervention. and we remind them of the language in both the Federal Register, Chapter 10. There's a plethora of information that's out there where it gives examples. But this dispatch protocol, if they're on EMD, this chart comes directly from EMD showing that Alpha and Bravo are typically BLS responses, where Charlie and Delta are ALS responses. And it's usually a pretty easy conversation to have with those Medicare auditors. Like I said, they don't always agree, but we've been very, very, very successful in getting a lot of those overturned in the tune of, millions of dollars of overpayments that they had assessed on our customers, and being able to argue those as valid claims. And I often say it was a gift that CMS gave us, and there's very little, I would say about 50% of the agencies across the country are actually have implemented ALS assessment policies and use that to their advantage. So the other that I wanted to just hit on, and again, this has been my soapbox for quite a bit. As you know, Regina Crawford, who's an employee of ours, she served on and I get the acronym wrong every time, but it was basically the congressional committee that reviewed and decided and MedPAC. Yes, thank you. But they were discussing a lot of things about whether or not we should go to No Surprises Act and should there be federal balance billing, etc. And interesting enough, in one of those meetings that I was asked to speak at, that we went down a path of this Medicare versus Medicare Advantage, certainly outside of their scope, but they seemed very interested and actually asked me to go back and provide them more data. And then I came back to speak to the committee again with my data. But it was certainly something of interest to them. And this is just this migration of all of our patients from a Medicare traditional plan over to a Medicare Advantage. There's lots of charts. I didn't include them for today's presentation, but Kaiser Family Foundation has a lot of charts. If we looked at our data internally through EMSMC, we would say around in 2018, we were about 60% traditional Medicare, about 40% Medicare Advantage. That is now flip-flopping. 1 second here, sorry about that. That's now flip-flopped. We're 60-40 the other direction, and nationally you can see here, and it depends on the region, but about 56% Medicare Advantage, and we see every single year more and more people are moving toward those Medicare Advantage plans. I often use myself as an example. For the last 10, 15 years, I've been on an HMO type plan or a PPO type plan. I know what my copays are going to be when I show up for my doctor's appointments. And when I go on Medicare one day, that's probably what I'm going to choose as a Medicare Advantage plan. So as our population starts to age out, we're seeing more and more in this push for more individuals moving toward this Medicare Advantage type plan and commercializing Medicare. But what does that mean for us and our reimbursement? We're starting to see that that's a pretty significant difference. So even though we start at the same place, both of them have to pay the Medicare fee schedule as their starting place, the co-payments, the amount that the patient is responsible for, significantly different on the ambulance side. I'm still a proponent. If we're going to go on Medicare, doctor's office visits, hospital visits, they're probably paying less out of pocket, but on the ambulance side, they're actually paying more out of pocket. And that it's quite evident in the data, and we're going to continue to watch that to see. But on average, nationally, we're collecting about 421, and this is mature trips. So this is after it's gone through the process, we've invoiced the patients, etc. So on average, our reimbursement for those Medicare Advantage plans are usually less because we're having to look to the patient to get those plans. The other point that I make is, a lot of these plans, they have to pay extra. So they're paying a premium for them to get their Medicare Advantage plan. It used to be this term called Medigap, And I really honestly hadn't heard that term in quite a while now, because, before, if I had my Medicare plan, I would spend my dollars to buy a Medigap plan, a Medicare supplemental plan, where Medicare was paying 80%, my supplemental insurance was going to come in and pay the additional 20. Now I'm using those same dollars to buy my Medicare Advantage plan. I'm not buying those secondary or supplemental plans as much, and therefore I'm responsible for my applicable copays and so forth. But at the end of the day, like I said, the Medicare claims are becoming more of a self-pay, where I'm having to go get the majority of that reimbursement from the patient, not from actually from Medicare. And I use an example, and this will be in the Q2 index form, but I wanted to break that apart just to show you what the dollars look like. So this was an example of a BLS emergency call with 5 miles. And so as you see that the BLS rate is the same, the mileage rate is the same, the reimbursement, the starting Medicare fee schedule is the same. With traditional Medicare, I'm going to receive $387 of the $483 that I can potentially collect for this trip. I'm going to receive that from Medicare themselves, and I'm going to go to the patient for the $96. That same claim under a Medicare Advantage plan where the patient's copay is $300, I'm only collecting $183 from Medicare, and I'm having to go to the patient to receive the additional $300. So again, things like collection efforts, again, that kind of rears its head. Days to payment. So if that's something that you're looking at, if cash flow is very important, and that where Medicare's paying in say 14 days, it's going to take me a lot longer to collect that $300 from the patient than I was accustomed to receiving in that 14, 15, 16-day time frame that I typically receive Medicare payments in. So certainly a difference there. The other thing that kind of throws a wrinkle in this is there's certain Medicaid plans where they call them QMBs. So they're paying their Medicare premium, but we can't balance bill the patient. In those cases, I'm only allowed to collect the $183.75. Not as many out there, it's not a high volume, but certainly a question that has come about at ABC 360 conferences and so forth. Don't have a lot to help in terms of fixing this problem, but I do try to share this data with anyone who will listen. And I think, we'll have to do something congressionally to fix this problem, to ensure that the Medicare Advantage plans don't continue to increase the copayment for ambulance services. And then the last thing that I'll go over with you all today is some data around commercial insurance claims. As I said, I believe there are 18 states right now that have some type of balance billing. And I saw a headline just this afternoon. I didn't get to read all the details, but the headline reads, I didn't expect to receive a $100,000 bill from an air ambulance. And one of mine, that's on the air side, and we've certainly seen a lot of the air side. There was another headline that was several months back, but it was a mother who her daughter was transported by a NICU ground ambulance, and the headline was that it was going to take her. I think the child was going to be 3 years old before the ambulance trip was paid off based on the amount that she was charged. So large headlines around this and no surprises, and should they be responsible for the difference between what their commercial insurance pays and so forth. And really this was the goal of the index, was to dig into commercial insurance claims. So understanding exactly how often are they paying. And several reasons for this. One, higher deductibles. I know myself, I remember when I used to have, say, $100 deductible or even a $500, and now that's $5,000 deductible. So commercial insurance is certainly changing. And so that's a big reason for these lower numbers. But the percentage of the patient's responsibility for commercial insurance claims came out around 16.6%. And to dig in a little bit further than that, we wanted to look at how many claims are not paid by the commercial. As I said, high deductibles where there's $0 paid by the actual commercial insurance. It could be non-covered. It could be them not, it could be a non-emergency service that is not covered or maybe not pre-authorized. Many different reasons as to why commercial insurance might not pay an ambulance trip. But the percentage of claims that were not paid by a commercial insurance company was 26.2%. That average payment was around 887. Big difference again, same, in the western states around $1,400, where mid-Atlantic around 487. A lot of that is how they establish their charges, their gross charges, and the rate adequacy for those systems. But then that average payment, which I thought was really, really interesting here, $176. That's the average amount that's not necessarily what they were responsible for. That's actually what we're collecting on average from a patient as a result of a commercial claim. So interesting information, as I said. Wanted to share that with you all and I think that this could be valuable as we go forward to try to implement balanced billing laws in those states in which they don't exist. And then this was the percentage of claims that were not paid by commercial insurance. Same information from the last slide, just more in a chart format, but around 26.2%. And then what I'll leave you with, and this was really the title of the session, but I wanted to include a lot of that information. What are some of the best practices for denial? So we've talked a lot about how claims are paid by the various insurance companies, but what are some of those best practices for denials? And it's really hard to talk about that at a higher level. So I really categorize this based on the type of insurance. And if I look internally for us, like what are those percentages that we receive denials for? Medicare and Medicare Advantage, it is absolutely every client is going to be eligibility and coordination of benefits. And there's no question. When I do a denial analysis for any of our customers, and let's face it, EMS is very different than, say, a physician's office where they're going to require that you bring in your card. They're probably going to be contracted with a lot of the payers. They're going to verify demographics up front. We're in the back of an ambulance running lights and sirens, probably not the best place to verify, the spelling of the person's name. So eligibility and coordination of benefits, but verification of that coverage at the time of billing. And I say that because even as EMSMC, we over the years had identified, so if we got insurance information, let's say from the paramedic directly, I have what looks like Blue Cross Blue Shield coverage, I have what looks like a valid provider or member ID and a group number, etc., then we found it was easier for us, if we're talking about days to cash, go ahead and submit that claim because the majority of the time that information is accurate because it came directly from the patient. And what we're finding these days is with the advent of the switching of Medicare and Medicare Advantage, Medicaid and Medicaid MCOs, they can change those plans frequently. And therefore, it's now better from our statistical analysis that we're verifying that up front, that we spend a little bit more time on the billing side to verify coverage, and then less denials on the back end. And so, more information to come as we have enough data to be able to prove that out. But it's not that I choose a plan and that's the plan for the rest of my life. I'm being inundated with individuals trying to sell me the next and latest and greatest Medicare plan or even Medicaid MCO plan. So verification and coverage at the time of service. And then these claim lacks information for adjudication. If you're in billing or in RCM, you know the CO16 code, and it can be a whole list of things. But things like spelling of the name, the demographics, the inconsistencies of Hicks-Picks modifiers, the pesky MBI. Many years ago, I think it was 2018, that Medicare moved to what they call an MBI number, and it's a 16-digit number that no elderly person is ever going to remember. And instead of it being Social Security number with an A, 95% of the time even if I didn't have their Medicare ID, I would have that information. This NBI is very different. And again, it's a string of alpha and numeric characters they're not going to remember that. But it was a push away, moving away from this social security number that my identity is going to be stolen. We're not going to use social security numbers to identify people. The funny thing about that story is, in order for me to get the NBI, I have to have their social security number. So in that case, it became a little bit more problematic for us to identify these individuals. If I look down to Medicaid, Medicaid MCO, I would say the same in terms of eligibility and coordination of benefits. It's always the leading reason for denial. Most of these Medicaid MCOs, where under the traditional Medicaid, I might have had a year to file the claim, we're starting to see as few as 90 days. In Matt's hometown of Texas, 95 days. That sounds like a lot of time to get a claim submitted to Medicaid, but most of the time, if I'm still tracking down which Medicaid they have, and then I get a denial, I mean, that 95 days is eaten up very quickly. And then with Medicaid, especially as brokers coming into most states nowadays, having to get that non-emergency claim either authorized by the broker or have a prior authorization, that becomes a problematic way of, in other words, finding ways to technically deny the claims. Commercial insurance, and we're starting to see that, as I said, I'm very supportive of balanced billing across the country, and as long as those balanced billing laws require the commercial insurance to pay an adequate rate for the ambulance service. But what they're doing as a result of that is cost shifting that back to the deductibles and co-insurance. And then there's other things like the non-covered services. We just saw that in the high rate of denials for commercial insurance companies. But utilizing that appeals process, exhausting the appeals process is what I should say. And then sometimes involving the patient. We're finding that, in some cases, that Blue Cross or that Cigna or that Aetna plan is actually going to listen more to their consumer, to their customer, so to speak, than they are to us. And so helping them to involve the patient. In some cases, they're sending claims back asking it to be paid at the network benefit because they didn't have a choice in 911 providers, for example. And in some cases, that might be beneficial. And then that coordination of benefits, again, having to involve the patient, because it may be that I've got two primary insurances. My husband covers me under their plan. I'm covered under my own employer plan. Who's paying primary? Another, like I said, just a tactic to get claims denied. And then on the patient invoice side, I would just speak briefly there. One of the things that we found effective is specific invoice type. So it's not a one size fits all. It's based on the actual situation. So if I only need a signature, it's a very clear request for signature. I have your Medicare on file. I don't have a valid signature. All I need is the signature from you in order to bill your insurance. Non-participating, if we're finding that the patient is being paid for services and you're not in network for that, making sure that that invoice is timed such that the patient invoice is received around the time that they're going to get a check, so that it's very clear that the check they receive from their insurance company is not theirs for going out to dinner, but it's actually for the ambulance service. And then, specific requests for insurance information if we don't have that on file. One of the things, and, several of our customers have adopted these prompt payment plans where, the invoice is very specific that you owe X if it's paid within 30 days, and it goes to Y if it's paid after 30 days. So if they're deciding which invoice to pay, yours might go to the top of that if there's some type of incentive for doing that. And then it's interesting to me, but we've just implemented things like Venmo and PayPal. We had a client to tell us the other day that they had to assist a 20-something-year-old in writing a check for their ambulance bill because they'd never written a check before. And that's just the generation, it's a different world out there. And so things like Venmo, PayPal, opportunities there. We actually implemented this and are having about 15% of our customer service calls actually using one of these alternative payment plans. This text statement, again, another way our customer service reps can tell our patients, if you'd like for me to send you a link via text message to either pay your bill or to provide insurance. And as I said, about 15% of our customers are taking advantage of that. So just alternative, being able to kind of meet them where they are. And then I throw this slide in here as well, just from an enrollment standpoint. And I'm actually getting this from our payer relations department. Make sure that, all of the information that you have on file at the Medicare or Medicaid offices, PACOS, Medicaid administrators, your payer portal access, it is so important that you keep that updated. And I'll tell a quick story and end on that, but we had a client who received a letter in the mail just this year, and it was actually a de-enrollment from the Medicare program, and it told them that they could re-enroll 10 years from now. So imagine their dismay receiving a letter like that from the government to say you've automatically been debarred from the Medicare program. And what this was is they're going back to look at who are your authorized officials, who are your delegated officials. At the time that you enroll in the Medicare program, you have to provide Social Security number, dates of birth, the person who's authorized to sign those enrollment forms. They have your information. And so in this scenario, there was a gentleman who hadn't really worked for the system, or actually been fired from the system about 3 years ago, had gone out and committed some felonies related to child abuse. And in that case, because he was showing up on this list of authorized offenders, and because he was tied to this particular provider as one of the delegated signers, they, no questions asked, they debarred them from the Medicare program for 10 years. Now, the end of that story is we jumped through a lot of hoops. We appealed the decision. We showed record where he had not been with the organization for a long time. But this is different than the OIG exclusion list. That's mainly around Medicare fraud and abuse and government type crimes, where they're digging deeper now under certain types of felonies that they say, we don't want these folks to be a part of the Medicare program either. And so that's really just my takeaway from this. But it is your obligation to notify if someone leaves the agency. We say immediately, but within 30 days of letting them know that they're no longer with the organization, because you're tied to them whether you like it or not, unless you correct those applications. So I think that was the last slide. So with that, I will open it up for question and answers.
With treatment in place, you had said each agency can develop policies that are palatable to their board or their constituents. Is there any regulations that require you to bill the patient? Like, for example, could we just bill the insurance companies we know will pay and not bill the patient, or not bill Medicare for the denial, that type of thing?
Yes, I'm glad you said that. And I should have had a bullet point. So there is an OIG opinion that was recently released about that. Now, it is specific to co-payments and deductibles and so forth. So not necessarily non-covered services. But the OIG did rule in particular for this particular provider, and you can read through all the scenarios because it's very well laid out. And they described their policy in being a municipality. They wanted to bill to the extent of insurance, but have a standard process in which they write off any applicable copays and deductibles related to TIP. And the OIG said that they saw very little risk and that they would not sanction them for an anti-kickback. So I'm glad you brought that up, but that has recently been published, and PWW has a lot more information on their website about it as well.
Just FYI, not only did the OIG say that it's likely not an issue, they made a statement in their opinion that it probably makes sense. that Medicare and other payers should pay for treatment in place because of the economic benefit downstream, which was stunning in an OIG opinion. But for those of you that don't know, the OIG opinion was requested by an AIMHI member agency. So very forward thinking on their part, and I'll find
Yeah.
it and send you guys a link to it.
Yeah, thank you. Hi, Rob, I see your hand up.
Yes, Kim, thank you for that presentation. That was superb. I put this in the chat anyway, but I'll ask. So, did I hear you say that we are now seeing companies, insurance companies, as an evidence, as direct evidence of cost shifting, actually increasing the cost of their plans now? Is that starting to come through in the balance billing states like California, etc.?
Yeah, it is. I don't know that I could quantify it just yet, Rob, because so much of it is new, but I know very specific examples. And on the air ambulance side as well, so that they're having to pay the QAF, but they're also, that the co-insurance and the deductibles are now being skewed, and it's more on the patient side. I think we need a little bit more data under our belt to be able to quantify that, but I'm definitely seeing that as a trend.
Certainly something that made my ears prick up there because, of course, as I tell anybody that's engaging in balance billing legislation, as we discovered, getting the bill through is easy. Managing the damn thing is exceptionally difficult. And every day
It's
there is a
very difficult.
challenge. There's a complaint. There's an issue. There is indeed, we have members in California that have actually litigated against and the Blues, for example. And so it's interesting to sort of see how they are testing and adjusting and tweaking sort of their side of it. The other sort of question or really comment I had is, one of the things I keep thinking we need to try and do somehow is educate the patient as to, the patient, or should I say the consumer, before they become the patient, the consumer, as to the small print of their health plans, the deductible, the EMS ride or not, the in-plan, out of plan. If you call 911, actually we don't care what plan you have. We're just coming to you because it's an emergency, etc., etc. If we can find a way of educating them so they realize what's going on and why we're doing what we're doing, that would be good. I mean, that's a huge project, but I guess always something
Yeah,
that has struck me. But thank you.
sure.
I
Yeah.
see Merg's got some questions in the chat as well.
And I will say, just as a follow-up to what you said on the balance billing, it's a huge component of insuring. So as you know, like the state law only applies to plans that are regulated by the state. And then you have to decide, okay, which plans are regulated by the state. Some of the balance billing laws actually say in the law that the insurance company is required to tell you whether or not it's a state funded plan or state regulated plan. Others do not. But then there's a whole process of deciding claim by claim. And, so Texas is an example where we were asking the question, how do we identify this? And they said, well, it's on their card. There'll be a TDI emblem on the patient's card. But from a billing perspective, it's very, very rare that I see an insurance card, a copy of one. And honestly, having, worked through Waystar Clearinghouse and others trying to find, is there some easy way for us to determine in California and in Texas and, Louisiana, all of those states, how do we then determine, is this a state regulated plan? And it's not as easy to say, okay, Blue Cross Blue Shield, because there are many plans Blue Cross Blue Shield sells that are state regulated and many that are not. And so it is a claim by claim decision as to whether or not it applies to AB 716 or if it applies to the TDI in Texas. It's becoming more of work on the back end to ensure that the claims are paid correctly.
Yeah, I don't want to steal Merg's question, but ERISA, of course, is a California conundrum because that is definitely not in 716. But explain that to the patient and or news at 11. That what's the difference? But I'll sort of let
Or
you look at
TikTok users, right?
Yes, California seems to have, yes, we have the massive media. The media inquiries are coming in, by the way, over that call you referred to. But I'll go to let you go to Merg's question in the chat.
Yeah, I mean,
Okay.
that's really it, right? I mean, I guess how much of the do you see a lot of ERISA plans asserting that they are not covered by the state balance billing laws? And along those lines, are there ERISA plans that are just adopting the state laws? Because many ERISA plans, the way, depending upon how they're set up, sometimes comply with state requirements just to sort of make it easier to deal with. And certainly they lose the moral high ground when the patient's saying, well, why are you billing me? And you go, hey, there's a state law that says this is the law. Your insurance company is not following it.
That's right. Yeah, and I would say that also is regional. Like in Texas, for us, it's kind of along the lines of those plans that are TDI are following the law, and those that are not required to. Washington State, very specifically, they said it applies to those that are regulated, but then the non-regulated agencies could opt in. And if you go to the Washington State website and this law, you can actually click on it and you'll see a long list of non-regulated insurance companies that have technically opted in. But quite frankly, makes it a little bit more challenging from the billing perspective. So now I've got to go to two different sources to see should this claim have been paid under the Washington State law versus, one of these opt-in or what have you. So it honestly, it's more work on the billing side from our perspective. We're going to do whatever it takes to get you all more money. But it becomes more and more challenging for us to regulate that and then appeal when they don't pay those correctly. One of the things, and I've joked about it, is even if the law says that you must give us a remark code. So, right, like I think it's an N830, if I'm remembering correctly, in Texas that they're using. So N830 says this claim was paid according to a state balance billing law. But I'm also trusting that the insurance companies are doing it correctly, right? So if they didn't pay the claim correctly under the Texas balance billing law, then they're not using an N830, and it's still not kind of foolproof for me to then decide, was this claim paid appropriately at the jurisdiction rate or the 325 of Medicare, or is this one that falls outside of that, and it's become more and more challenging.
Those remark codes are always correct. I don't know why.
I know, exactly. I should, yeah.
That's great.
Kim,
Yeah.
real quick to the question about billing for treatment in place. Great information about the OIG and whatnot. I would also suggest that you won't know which insurer is going to pay for treatment in place until you bill them.
Mm-hmm.
And what we found at MedStar and a lot of other organizations are finding is that a surprising number of insurers do pay it. You can have a policy that says, hey, we're going to bill normally like we would bill for a transport, and then have a policy, if it's denied, that you're going to write it off or whatever the case might be, and have that built in as part of your financial policies or your RCM policies. But I would not suggest perhaps that you restrict it only to billing for insurance companies that you know is going to pay, because we didn't know, and holy crap,
Right.
it's a shitload of
Yeah.
that are paying, especially on the commercial side. Medicare, obviously not. Medicaid is dependent on the state, but strictly in regard to commercial insurers. And to be fair, a fair number of the reimbursements that we're getting for those services are from Medicare Advantage plans.
Yeah. And I would say across the board, if you're going to charge for it, that you should treat all insurance companies the same. And it becomes a nightmare to try to figure that out, like you said, to bill this insurance because they know they pay, and not to bill this insurance because they don't. But establishing some charges across the board, and then determining that, from the data analysis to see which insurance companies are covering it. And then the OIG opinion allowing you to do some, automatic write-offs of copays and deductibles. It makes it much easier to implement those policies.
I just think one of the problems that we have that we've seen, and you got some EMS agencies that think that treatment in place means billing for a refusal or billing for a lift assist when they haven't done anything.
Mm-hmm.
Right? They've gone and given the stare of life, and the patient says, I'm not going to go. And, people are like, hey, let's treat in place. We can bill for that. And try explaining that. right? I mean,
Right.
that's where it starts getting a little dicey, where people might be a little over
Well,
their skis thinking that treat in place is a panacea.
yeah, no, agreed. And that's why I like this, and I've still got this slide up, but this Illinois bill, and they've actually looking at it as an evaluation without transport and then a treatment without transport. I thought that was interesting take on it because, in our world, it's the TNT service. It's however you set that up in terms of what is a billable service.
And if you think about the way that the American Medical Association, who does all of the, different stuff, but even CMS, who has the HCPCS code for AO998, the short definition of AO998 is ambulance response
Response.
treatment without transport. Okay, so an ambulance has to respond, there has to be treatment, and there has to be
Mhm.
no transport. So when you combine those three things together, it makes it relatively defensible what you're going to choose to bill. If you do a lift assist and there's no treatment, it's not eligible.
Right.
Um,
The MVA example as well. Like that's the other example of, everybody gets out and they're fine, and five people have called 911 because they saw the accident happen. So, but that, yes, absolutely. And that's why I was, giving this as an example here. These are just two clients without a lot of documentation from Medicare, because Medicare always sets the standard and then everybody else follows it. In this case, Medicare doesn't have a standard. So you do have some flexibility around that, but you can be very specific again in what you feel like your community could offer, or what your community would support.
I think our board would support it as long as we're not required to bill the patient, because you get those complaints that what am I paying taxes for, and it becomes a political issue. So I think
Sure.
that OIG opinion will be very helpful. I had another question. It's kind of funny because you brought up the OIG opinion. And we have a situation where one of our hospital systems, they have, of course, freestanding ED, and there's several transports, from their non-emergency to their main hospital. And they are, so we bill Medicare, and Medicare sends us a denial saying, bill the provider, they're being paid under Part A, because I think Medicare opines that as soon as that doctor makes the decision that the ED, freestanding ED, you're going for admission, even though the hospital doesn't admit the patient until technically, right, after the transport, Medicare is still considering them inpatient, and they're telling us the hospital's being paid under Part A. So we bill the hospital, and the hospital saying, no, they weren't admitted. We're not responsible for this bill. So we're in a situation where we agree to disagree. And of course, from a billing standpoint, we would like to litigate. However, politically, I don't know that that's going to happen. So my thought was, is this something we could request an OIG opinion on if we're prevented from, if we won't get the authority to litigate?
Yeah, let me send you some information. I'll send it back to you. What we're finding across the board is that if you tell the hospitals that if they admit them while they're still at the freestanding, that they're responsible for the bill, they'll stop admitting them until they get to the main hospital. And so in most cases, we are billing those to Medicare because they technically didn't admit them until they got to the hospital. But there's actually some criteria, and so you look at the provider numbers, not the NPI, not the tax ID, the PTAN of both facilities. Then you look at, are they within 250 yards of the campus? Then you look at what, and I often say this, what is the status of the patient while they're in your ambulance? And if they have not yet been admitted by the time, and most of the freestandings will tell us, of course, they haven't been admitted. We don't have admitting privileges. We don't have beds here. And so, and a lot of times I'm looking at the face sheet too, because the face sheet will say inpatient or outpatient. And then that helps me to determine. but sometimes it could be the difference in a couple of hours that the admission paperwork was signed at 1 p.m. You transported them at 2 versus you transported them at 2 and they didn't actually admit the patient until 3 p.m. or 4 p.m. It is based on what's the status of the patient in the back of the ambulance. There is some language in Chapter 10 that goes a little bit further that talks about outpatient hospital settings, even if the patient is subsequently, and I'm trying to quote it from memory, but even if the patient is subsequently admitted after they arrive at the hospital, that might be more language that you need to get Medicare to pay for those if you are getting denied. But that's where we've been successful. And then if it's a scenario in which it's inpatient, a lot of the times where you're just going to be doing these for the hospital and you know they're going to be inpatient at the time of transport, it's setting up an arrangement or a contract in which you're billing them, say, a monthly invoice rather than individual 1,500 form type thing. So happy to help you with that. I've got quite a bit of information. We've had to research this quite a bit lately, so I'm happy to help you with that.
Kim has her three-way test that she talks about at ABC 360.
Yeah.
Yeah. Yeah. I thought at a PWW conference, they opined that as soon as the doctor at the freestanding ED makes a decision that this patient needs to be admitted, that technically that's when they become an inpatient, as opposed to when the hospital conveniently, goes into the system and like it becomes a technical issue because I didn't admit the patient till 10 o'clock at night.
Yeah.
Or whatever the case may be, but the doctor at the freestanding ED said at 9 a.m. they need to go for an inpatient to be admitted. That's the determining factor. But I don't know if there's anything if that was just their opinion or I don't know. Is that
I would agree
familiar at all?
Yeah, I would agree with that opinion. I mean, it's when they have actually admitted that patient, signed the admission paperwork for that patient to be admitted. But what we see is, like I said, the change in behavior once you tell them that they're just going to stop admitting them until they get to the hospital. But I was going back, and I'll put the link in the chat as well. But there's, let's see. Yeah, it basically says the transfer of the discharge of that beneficiary from one provider to with a subsequent admission to the other provider. And it says an outpatient, hang on, I'm sorry, I'm doing this from outpatient. This includes an outpatient transfer from a remote off-campus emergency department to becoming an inpatient or outpatient at the main campus, even if the ER is owned and operated by the hospital. And I think that's the pertinent part that you needed for your argument. But yeah, I'll put this in the chat and I'll send this over to you separately as well. So
Okay, I appreciate that. I know we're running out of time. Do you have a few minutes to talk about
I have all afternoon. So and I said for the others, if they wanted to leave, you're happy to, but I'm happy to continue conversation.
Yeah, and I'm one of those people. I have to jump, but Kim, thank you very much. This was fantastic. At 6 million claims, I'd probably be curled up in a corner.
There's a big team.
I'd say. But thank you
But
very much.
yes, I appreciate you. Yeah, absolutely. I appreciate you being here.
No, this has been fantastic and very helpful. And it'll be great for the entire membership once Matt puts it up for everyone to access.
Okay.
Thank you again.
Thank you. Have a great evening.
So in Pinellas County, we are our ambulance system. We're a PUM, public utility model. We have one ambulance contractor who provides all services, emergency and non-emergency. And up until we've seen this non-emergency pre-auth trend, we were getting paid fine. But in 2014, Medicaid transitioned to managed care, and they started requiring the pre-authorization. Mm-hmm. And so we're seeing that trending to Part C plans, commercial plans, and so forth. So we are really getting a lot of pushbacks from the hospitals to get that pre-authorization. And many times we as the provider are not authorized to get the pre-auth, right? They don't, sometimes some plans will, some plans won't.
Yep.
And I know a lot of systems, they contract with the hospitals as a payer of last resort, or they contract at a reduced rate. They have all these options. Well, as a government agency, our county legal has opined that we cannot contract at different rates with different hospital systems, that our rates have to be, our rates are legislatively set by our Board of County Commissioners. And if we want to contract at a rate other than that, it also has to be included in the fee schedule approved by our Board of County Commissioners. So it's not an ideal situation as a government
Wow.
agency. So we don't have the flexibility a lot of private systems have. So I don't know if you have experience with other government agencies and this, you know, the problem is in Florida, most other counties have private ambulance doing their non-emergencies. So they contract and they have the flexibility. Yeah. So, you know, the hospitals are calling our commissioners. There's gonna be delays. We already have delays. We can't clear our beds. So now we have to go before our commission in October and do a workshop and educate the commissioners on why, you know, we're trying to partner with our hospitals and get this pre-authorization. It's costing us $1 million plus annually.
Wow.
So I don't know if you have any advice or.
Yeah, I mean, it's an issue across the country, I would say. You know, a few things I would say, even when I worked at Medicare, people would say, Medicare, you need to go out and educate the hospitals and let them know how we bill ambulance claims. It's very difficult in doing so. That you don't understand how they bill their hospital claims, don't expect them to understand how you have to bill yours. We have done some pretty successful sessions where if we can get to the right people and have sit down meetings and help them understand, especially around the broker system and them having it not necessarily a prior authorization, but just that they have to call the broker first. They can't pick up the phone and call you. They've got to call the broker, allow the third, it's a broken system, but we've got to deal with the broken system that it is. And that, you know, here's some kind of cheat sheets. I know we did that here in North Carolina when brokers came. We had a little cheat sheet that we were trying to get to as many discharge planners as we could to say, call this number if you need an ambulance ride. But it was part of that is just educating them and helping them to understand it. And then even without a contract, like there's plenty of times that I've built a facility without a contract in hand. And that acts as a deterrent, if anything, because I think Matt said this yesterday on our webinar, if they start getting bills for it, then their process changes. Or if you can get to a CFO or somebody who understands, because your payment is depending on them doing the right thing. But if they don't always understand what the right thing is and being able to, you know, help educate them, I'm happy to jump in. I mean, we're partners, so I'm happy to jump in there and help you with some of the education or try to get to the right people. We've got like an off-the-shelf little facility documentation guy. I don't know. In some cases, our clients that they've you know, bought breakfast, and Doug or Steve would get mad at me for saying buying them breakfast because that might be an anti-kickback. But you have an event in which they might come together to eat, and that it's an educational session, and it's really like an off-the-shelf, like we talk about physician certification statements, who can sign them, what information do we need on them, who needs a prior authorization and when. You know, interfacility transports. We talk about consolidated billing, this idea of this freestanding versus, you know, the package or the 3-test rule. Like you know, we could come in very, very easily and create a little 30-minute training session that's based on facilities that we could offer to you all in Pinellas County. So
I'm just showing this screen share. One of the things that we did in Texas was we got the Texas Medicaid program to adopt a rule that if a sending facility does not get prior authorization, because we're not allowed to get authorization as the provider, that if the hospital, SNF, whatever the facility is, does not get prior authorization for a Medicaid trip, they are responsible to pay the bill. That is a Medicaid rule in Texas, and they have to pay. And if they don't pay, they get fined. So work with the Florida Ambulance Association and others, see if there's a way that you can put into either administrative code or if it requires legislation, that they have to pay. And if they don't get authorization. Now, in some
That's
cases,
great.
we were able to extend this to, most of them were for non-prior authorization. But in some cases, we said, hey, same sort of principle for non-medically necessary. So the claim got rejected by Medicaid for not medically necessary. Now, if they had tried to get prior authorization, they would have been told that, but you can use it in a number of different ways. But this saved our bacon. And this was
Yeah.
put into place, I think, in 2015.
That's great.
That is great.
I'll drop this in the chat for you.
Yeah, that would be helpful. Yeah, I would love that. But I just don't, I'm having a hard time understanding where the hospitals are coming from, because they just recently issued a paper, their Florida Hospital Association, and talking about how pre-authorization, nothing to do with ambulance, but just other pre-authorization, is costing them millions of dollars because it's delaying discharge. They're not able to clear their beds. And now they feel like this is just another layer. And we keep hearing, you're trying to pass your problem on to us. Well, it's our patient's problem, because, and depending on the insurance, if you don't get pre-auth, we bill the patient, and that's not fair, right? So
And Medicaid, you can't, and so
right,
then you end
Medicaid,
up
we
eating the
can't.
bill. Yep, I understand for
And,
sure. It's a
and I think they already do a lot of pre-authorization, so I just don't understand why they can't bake this in with their existing work, especially on the low-hanging fruit. Like, you got the 80-year-old coming in for a hip replacement, she's going to need a ambulance to go to the rehab. You don't have to.
There's some programs that are getting a lot of traction. One is called Ride Central, and another one is called Round Trip. And so these are programs that come in, and they're more like, their customer is the hospitals. The hospital's got to buy into it, but they assist them in organizing and creating, so they can order an ambulance transport without having to pick up the phone. And that order comes directly to usually their inter-facility transport division. But they're also trying to automate these prior authorizations and the obtaining the PCS forms, like all of those things are, like I said, they're getting some traction across the country these days, to try to make it easier for hospitals to get those types of authorizations. But I don't have, any great words of wisdom, because it is truly a problem across the country. And the other soapbox that I would have is that these broker systems are set up to make it complicated, because so many of our clients say, well, I'm just not going to deal with the broker. We'll just eat that transport. And then that benefits the broker. And so therefore we've got a vicious cycle in which they're not paying for all of the transports that are being rendered. And so,
Actually,
it's an issue.
our ambulance contractor, Patient Care of Florida, they do have Ride Central in place in one of their operations and north of us. So they are actually working on a contract to get it implemented for Pinellas County. So we do have that in the works. So I'm hoping that'll be helpful.
Yeah, that should help. Friend of mine, Todd Sheridan, used to work at Fitch and Associates, actually working at Ride Central these days. So if you need anything from that perspective, let me know. He's a great EMS advocate for sure. So.
Oh, okay. Oh yeah, and then, like, for example, the freestanding EDs, they're telling us we have to get this, even though it's not emergency. If we wait, 3, 4, 5 hours for a pre-auth, the patient's condition is declining. And now you're putting us liability issues. So they're coming from that angle. We have, I believe, one of the few infant or pediatric nursing facilities in Pinellas County, and they have to transport some of these kids who are on vents, and they're waiting days to get a pre-auth from these transportation brokers. And so, we understand so it's not a good, it's really non-congruent for an ambulance. And I wish we could get some legislation that would not allow insurance carriers to require pre-auth for non-emergency ambulance, especially in those situations where maybe it's not acute, but you do have that patient's medical conditions that's going to decline. They can't sit in the freestanding ED for, all night while they wait for a pre-auth.
We were successful in North Carolina, especially was that we wrote into the broker, and this is kind of before the fact, but we wrote into the broker rules. We still, if it's non-emergency, we still have to bill the broker. But if it was hospital to hospital, we didn't have to have a pre-authorization for that trip. So they were still required to pay for it under the broker program, meaning I couldn't bill the MCO, but I didn't have to call and wait because of what you just said, like a 3-hour. They gave us a 3-hour window, but a more realistic was, like you said, it might be days. And so we were able to write that into at least the regulation, not necessarily legislation, but regulation, that they could not require us to have an authorization for hospital to hospital.
So yeah, that would probably be something we would need to get the Florida Ambulance Association to work towards and work with ACA.
Yeah, absolutely.
Kim, do you know how many clients you all have in Florida? And the reason I was asking is because I was going to ask you if you would be able to provide me with any that currently charge for treatment in place, because that's one of the things they always ask. Well, what are other communities doing? If we can demonstrate the other communities in Florida are doing this, and then I can reach out to them and see how much they're generating. Obviously, that would help us, because we have presented this before and it just wasn't politically palatable. But because we're losing money on this non-emergency, and like you said, the change in the payer mix, we have to go after every dollar that's available.
Yeah. So yeah, Matt's going to have the data that we pulled for 2024, but I will go back and we put that into regions, but we have it at the state level for sure. But I can go back and absolutely get you a full list of all of our Florida clients that are billing TNTs and then what that reimbursement is.
Okay, I appreciate that.
Have you guys seen the April 2025 report from, I think the ACA or the health department, I think in Florida, contracted with Milliman to do a report on what is the advantage to the patient and the payers for paying for treatment in place? Have you seen that?
I
Oh,
haven't.
Okay, I had the opportunity to edit it before it got released. I'm going to drop it in the chat, but also make it available to the reimbursement committee.
that'd be great.
And Kim, if you haven't seen it, I'll send it to you as well.
Okay.
Perfect.
So nobody sign out until I drop this file in there. Hold on.
No.
Payment reform. Tip. Florida, here it is. The Reader's Digest version, hugely beneficial to the patient, hugely beneficial to the agency, but more so beneficial to the payer. So you might be able to use this official state report in some of your political messaging.
Yeah, anything you can do to keep them out of the hospital is going to save money, right? So
yeah,
Unison is faster, because I'm sure what Baycare still has delay issues, right?
they've gotten a lot better. but, you know, that's kind of what the excuse they're using to, the whole pre-authorization. We need to clear our beds. We don't want to clog up your system. And so, you know, their CEOs called our board members. And so, yeah, now we're scheduled, I think, the first week in October to do a workshop and educate them on why we are trying to obtain this pre-authorization.
Okay.
Mhm.
Either insurance can pay it or the taxpayer can, you know, the taxpayer or the patient, you know. So anyway, just trying to frame that in a diplomatic, professional way to get their buy-in.
Yeah.
Well, I appreciate you staying on and
Yeah,
answering.
absolutely. Good discussion. I appreciate you all being a part of it today.
Yeah, very helpful resources.
All right. Well, we'll talk soon and I'll be in touch with all that information.